All right, so it's 11:01, so we'll go ahead and get started. Hi, everyone. Thanks for joining us. I'm Angela Hefner, the co-chair for the Families in Health SIG, and I'm excited to introduce our speaker for today's webinar, Dr. Maggie Smith. Dr. Smith is a marriage and family therapist. She's an assistant professor in the Department of Family and Community Medicine at UT Southwestern Medical Center in Dallas, Texas. She provides in this role integrated psychotherapy in the department's primary care clinics, as well as supports the department's residency education and also does quite a bit of supervision for MFT trainees. In terms of her research, she focuses on the role of the family system in biopsychosocial health outcomes related to weight talk, body image, and sexual and gender identity. Specifically, she's really passionate about developing family-based interventions to target health disparities for sexual and gender minorities, as well as individuals affected by weight bias. So, Maggie, I'll pass it over to you.
Awesome. Thank you, Angela. Good to be with all of y'all today. Like Angela said, my name is Maggie, and I'm excited to talk to y'all about weight stigma in primary care, but most importantly, how we can dismantle weight stigma in primary care. What are some ways that we can talk about weight and body image and food, all of the things a little bit better and a little bit in a more patient-centered way. So we're going to talk through different aspects of weight stigma. What is it? Some prevalence. What do we know that it contributes to outcome-wise? And then also, like I said, focus mainly on what does that look like in primary care, and how can we, as behavioral health providers, as providers in an integrated system, how can we advocate to dismantle weight stigma? I am going to have the chat open the whole time, so feel free to send any thoughts, questions as I'm talking. Also, unmute and speak throughout as well. I want this to be as helpful as possible for y'all and to address any questions that y'all have coming into this. So speaking of, I have a few questions for y'all to start out. Feel free to put this into the chat, or if you're feeling brave, unmute. But I'm curious what, if any, and that's okay if it's none, are y'all's past experiences with education around weight stigma and weight bias?
Hi, I'm Imani. My experience has been um, very little. I think in my MFT program, we didn't really talk about it at all. We talked about discrimination across various um, avenues or demographics, but weight bias, weight stigma was not something we talked about. But as students, that was something we brought up. And we're like, hey, why aren't we talking about this? So no education, but something we all thought about and cared about.
Yeah, thank you so much, Imani, for sharing that. So it sounds like there were maybe limited experiences of actually talking about this in your training, but there was a recognition that there was a need to talk about this because maybe you were noticing it was a common experience for your patients, for your clients, for a lot of times for ourselves, for our family members. But noticing that, okay, we're talking about discrimination, we're talking about bias, which is awesome, and we need to continue that. But maybe we're missing part of the conversation by not addressing the role of weight bias. Awesome. Thank you. Any other experiences in the past with weight stigma or weight bias education? I'm going to take the silence as probably not a lot, which is super normal and common. I think, like Mani pointed out, that this is probably a gap that a lot of us have in our training and our education. But especially for those of us working in primary care, it's something we probably experience a lot. And we're probably, wanting to be as patient-centered, as family-centered as possible, wanting to figure out how do we have better conversations about this. So with that being said, I'm curious what your initial reactions are when hearing the phrase weight stigma, and also what you're hoping to learn today. So what you're hoping to maybe get out of our conversation about weight stigma.
I will jump in. Hi. I was a little late, so I didn't want to speak at the first one to make sure I understood what was being asked because I had to
Sure.
eat up my lunch. But I am a licensed social worker working as an eating disorder specialized therapist, and I'm currently transitioning out of private practice into a primary care setting, focused on pediatric and adolescent care. And I'm hoping to take, honestly, the place I'm going is really wonderful in terms of like the foundations that they have already on trying to do like anti-diet,
Mhm.
like nutrition care and addressing eating disorders in all bodies and addressing weight stigma. But I really want to be able to, from this, learn better how to bring the skills that I already have a little bit out of like a very specific clinical space into a primary care setting, and to support also, especially those in like younger ages where there's certain vulnerabilities, and also addressing a lot of like where I specialize to the intersection between minoritized identities and eating disorders and weight stigma, especially even if with like gender diversity. So I was really glad that this was happening.
Yeah, fantastic. Thank you so much for sharing, Lexi. It sounds like there is some experience in a setting where maybe people shared a paradigm around food, around body image, around how to talk about food, how to talk about weight, how to talk about body image, but now shifting into a primary care setting. How do we collaborate or work as a team with folks who might have a different paradigm? How do we meet them where they are in certain ways? I'm also advocating for change in others. It's an excellent thing that I hope that we feel a little bit more confident in after today, but also it's an ongoing process for sure. So thank you for sharing. I'm seeing a couple things in the chat. So Jessica says, listening to a podcast calling it fat bias. Yes. So you'll hear me use kind of different language throughout today. For a lot of folks who experience weight stigma, they prefer the identifier fat as a way to talk about their body size, talk about their body weight. In a lot of ways, that is a way to reclaim a word that has been used in a stigmatizing and negative way. So you might hear me use that throughout. In general, when working with patients, I model patient-centered language. So whatever word they're going to use, I'm going to use that back. So for some patients, that's obese, that's overweight, that's that is thin, that is larger bodied. So depending on what the patient uses, that tends to be what I mirror back. And tends to be what I coach physicians to do as well. Sometimes they will use language that maybe the patient didn't start out by using, and that can be important. But yeah, hearing it called fat bias and can't stop thinking about it. So there's a lot of layers to that, a lot of nuance. Terry says working in primary care and looking for information about how to recognize and address it. So what does it even look like? I think sometimes we don't recognize maybe some of the ways that we're languaging things, or some of the ways that we're talking about or conceptualizing cases, that it might be stigmatizing for folks. So how can we even catch it within ourselves and within our primary care systems and address it? Kathy says ways to talk about weight stigma with medical providers and teams. So yeah, verbalizing how we can make some shifts in our language and how we talk to patients, and do it in a way that is heard, right? So there's a fine line there of how do we make sure that we're using some shared language with our physician colleagues, but also maybe advocating sometimes for a shift in language as well. Excellent. Thanks, y'all. I'm hoping that our conversation today will cover a lot of these things. I also heard, I think Lexi said this about intersectionality and how that impacts our patients as well. So yeah, hopefully we'll address those things today and have some opportunities for discussion and questions, and we can go from there. But thanks y'all for the participation. I love it. So we're going to start with just some basics on what is weight stigma. So weight stigma is the social judgment of individuals perceived to be overweight or obese, which can lead to prejudice, discrimination, and negative stereotyping. You see that I'm choosing to use that asterisk in the word obese here in this definition, just because for a lot of folks, the word obese can be stigmatizing in itself, which is why I said at first that it's important to model patient language. For some patients, that feels like a fit and they're comfortable with that language. For others, it can be really stigmatizing and actually can perpetuate bias. This might be one where we have to give and take with our provider friends, right? This is something that's very much a part of their lexicon. And so kind of judging when it's helpful to advocate for a language shift and when it's not. But just wanted to add that context for the definition. What we do know about weight stigma is that it is extremely prevalent and it is rapidly increasing. So there was a recent study using data from the implicit attitudes test, which I'm sure a lot of us have taken that through Harvard. But what we do know is that 40 to 50% of folks experience weight stigma globally. And from this recent study, we know this is across, I think it was 2006 to 2017, so a lot of years, that other areas of bias are moving towards neutrality. This isn't to say that there are not still other areas of bias that we are working to address, because there are. But in a lot of other areas, we're moving towards neutrality or in a positive direction. However, weight is the only area that has increased since the start of the study, which maybe goes to show, and this is something that Amani was talking about, that this is something that's happening that maybe we're not addressing as directly as we need to be. This is something that is impacting our patients in pretty significant ways and impacting us and our families in pretty significant ways. But it's something that we're maybe not talking about and maybe not figuring out how can we advocate for change in this area. So that's influenced weight stigma by multiple different myths that we have about body size, about BMI, about weight. And a lot of these are pretty prevalent within the healthcare system. A lot of this is stuff that our physician colleagues are probably taught a lot in med school. And so there are a lot of myths that are not intentional, but are probably implicit in their training of what we believe about weight. So the first is that thinness equals health. This is a common myth that if we can look at a patient and see that they are thin or see that they have a lower BMI, that automatically means that their health outcomes are also going to be positive. On the flip side, there's an assumption that fatness equals unhealth, right? So it's this idea that we can look at a patient, we can look at their body size, we can look at their BMI and their chart and automatically know about their health. The problem with this is that when we come in with that negative assumption for our patients in larger bodies, that can impact the type of care that we give. It can impact the type of questions we're asking those patients, the amount of time we're spending on physical exams, on assessing root causes. It also means that we can miss certain health concerns in our thinner patients because we're not asking important questions. So really this affects patients across BMI when we assume that health is equal to BMI. In fact, there's so many other indicators to health. And also, there are so many different pieces of health, as we know, as behavioral health clinicians, there are multiple aspects of health, that biopsychosocial model, that are equally as important to biological health. So, and I'll talk about that a little bit in a second. I'm also trying to monitor the chat as we go. Yes, Lexi, we'll make sure that you get everybody gets a copy of the slides. Yep, and some magnitudes have a hat on weight stigma. We'll get to more of that, Kathy, and curious to expand upon that. So another myth that is common is that weight and weight loss are controlled through individual behavior change. A lot of times, stigma can be perpetuated by the assumption that if a patient just changes their diet enough or exercises enough, they're going to be able to achieve a considerable amount of weight loss. The truth is that sometimes weight loss can alleviate certain health outcomes. There are times when weight loss can improve health, and there's times that weight can impact health. However, when we look at the ability to change weight just through the individual lens, we are perpetuating a lot of times blame and personal responsibility that are not fair to be putting on our individual patients. What we do note about weight and weight loss is that genetics, trauma, access to certain types of quality food, so people who live in food deserts, these are also things that are contributing to weight that are much more systemic. And so when we're placing all that responsibility on our patients to make individual behavior change to achieve weight loss, and that's the expectation, and patients are consistently not able to meet that just because it's not possible for a lot of our patients. So how do we talk about health? How do we help our patients improve health when weight loss is not feasible, right? For various different reasons. But that's a common myth that if people just worked harder, if they just ate less, if they just exercised more, they would just lose the weight, which can lead to maybe beliefs of people being lazy or not working hard enough. And obviously that's going to impact the patient care that we provide. Another is that encouraging people to lose weight or constantly talking about weight loss and making that a constant goal for all patients will result in weight loss. We actually know that body talk and weight talk and fat talk don't necessarily result in weight loss. And so especially if our patients are coming in and this is not a goal that they have set as something that they're wanting for their health and we're just prescribing it onto them, that actually can have the reverse effect. It can lead to weight gain and it can lead to all sorts of different health outcomes that we'll talk about in a second. So this is a common perception that it's a motivating thing if we consistently talk about it with patients all the time, but it's not necessarily motivating, like I said, if it's not one of their own goals. Okay, so biological health being the most important value for all people. So I think a lot of times, obviously in healthcare, there's a big value on physical or biological health. And that is something that is not necessarily the case for all folks, right? So some people might come in with some physical health goals, but other people, maybe depending on their history with body image, history with disordered eating, they might need to prioritize more of their relationship to food, their relationship to their body, their relationship to mental health in an equal way, which might change the conversation about what we're talking about or what their different health goals are. So reminding ourselves that health is not moral, food is not moral, body size is not moral, right? And that not everyone is going to have the same values around these things. So how can we make that as patient-centered as possible? Um, and also how do we make sure that our goals are fitting within what our patients are saying their goals are? And I know that for a lot of our patients, we are talking about things like Ozempic, we're talking about things like Wegovy and Mounjaro, and patients are coming and asking for these things. And so we'll get to that in a little bit of how to talk to our patients who want to achieve weight loss, who that is a goal. How do we talk them through maybe different pieces of that goal and help them shift to maybe overall health as a goal as well, in addition to weight loss? So we'll get to that because I know that is probably a common thing we're all seeing with our patients. So what does weight stigma contribute to? What do we know about health outcomes related to weight stigma? So in terms of biological health, we actually know that the perception of being overweight predicts increased blood pressure, inflammation, HDL cholesterol, triglycerides, glucose, and HbA1c levels. So a lot of these things are things that traditionally are associated with obesity or traditionally associated with increased BMI. But you'll see some similarities that some of these outcomes that we're associating with only obesity are also equally and independently associated with weight stigma. And we actually see in a lot of studies that this perception of being overweight, this perception of a larger BMI, actually plays a stronger role than the BMI itself in these outcomes. We also know that weight stigma and discrimination can lead to weight gain. It can lead to metabolic syndrome. It can lead to increased caloric intake as well as avoidance of exercise. So we're seeing that any stigmatizing or discriminatory experience for folks actually leads to decrease in a lot of health behaviors and also an increase in a lot of adverse health outcomes. In terms of mental health, the list is rather long of what we see with weight stigma. So it leads to depression, anxiety, disordered eating behaviors, unhealthy weight control behaviors, suicidality, low self-esteem, substance use, negative body image. I mean, pretty much runs the gamut of what it contributes to mental health wise. And obviously, as behavioral health providers, this is really important for us to be aware of and to advocate for when working with physicians that mental health is a part of health, right? We can't only focus on physical health outcomes and lose sight of these mental health outcomes. We actually have also seen, similar with the physical health outcomes, that weight stigma explains the relationship between higher BMI and mental health outcomes. So there's a lot of research that shows higher BMI or obesity leads to similar outcomes, but we're starting to see that that's maybe a little bit more complicated than we originally thought, and that weight stigma is mediating or fully explaining a lot of those relationships. So all of that being said, is that the relationship between weight and health is complicated. And the role of weight stigma is super important for us to understand as providers when trying to treat these outcomes for our patients. So what can stigma look like in primary care? We've talked a lot about of what it can lead to. We've talked about some of the prevalence, but what does it actually look like when working in a primary care setting? It can look like conducting shorter exams for patients with larger body sizes. So if a patient's bringing a concern and a provider is not spending as much time as they would with a thinner patient on exploring what that is physically, physical exam-wise, that can be a stigmatizing experience. Spending less time on education for patients with larger body sizes. So not talking about the condition or providing the same amount of education that they would for thinner patients. And over-reliance on BMI as an indicator of health. I'm sure that we have all been in the precepting room or been in the room with the attendings and hear them talk about a patient they're about to go see, and they're like, oh my gosh, their BMI is XYZ. You can hear just the negative attitude they're about to go into the room with, and also how they're already relying on that BMI as the primary indicator of health. Or maybe you're hearing them talk about health out or talk about a visit, and they're talking about, oh, well, this patient was able to lose weight, but we're not hearing them talk about the actual health outcomes, right? So we might see this a lot with our physicians that we're working with. Another is the physical space. So lack of inclusivity in terms of the physical space of our clinic. So having too small of chairs, having too small of gowns, having scales only in public spaces and not offering to weigh someone with their offering to cover the number or with their back turned. Maybe even looking, oh, you just had a visit 2 weeks ago. Maybe we don't need to weigh you again, right? So how do we make that as patient-centered as possible? But a lot of times our physical spaces are not inclusive of all body sizes. A belief that patients with larger body sizes are lazy or less healthy. Again, we probably hear this with good intention from our physicians and colleagues and even our behavioral health colleagues a lot. There is good intention maybe behind wanting to achieve health for their patients. But sometimes you can hear this belief that maybe these patients are lazy. They're not trying hard enough with their health. They're annoyed going into the room to start because they've been stuck for so long trying to improve different health outcomes, and they're blaming it on the individual and on their ability to lose weight. And again, this assumption that a patient wants to lose weight just based off of their BMI. So maybe you're looking at a BMI of a patient and you're automatically assuming that one of their health goals is weight loss. And instead of having a conversation with the patient about what are their health goals, just immediately jumping into a conversation about weight loss without understanding any context around their experience with weight or weight stigma. So these are some broad examples of what it can look like in primary care. I'm curious if y'all have any ones that you would like to add or anything you don't see on this list that you've experienced. You're like,
I'd
no.
like to actually point something out as
Yeah,
something
Chris, go
that
for it.
I've experienced in primary care. It is consistently suggesting the same exact routes for weight loss for people with larger body sizes. So the main thing is, well, you should probably just exercise more. I think I've heard that over and over and over again. I could probably play it like a real good record.
Yep. 100%. Thank you so much, Chris. We're
I
not
think too-
shifting our recommendations, right? Based off of our patients' needs. And if we see this all the time with all sorts of stuff. And that's part of our role as behavioral health clinicians is how do we help our providers talk about goals, talk about behavior change in more effective ways. But if we're suggesting the same thing over and over again and not exploring the barriers to why that's not working, then that's pretty stigmatizing and discouraging for patients. Jessica, I think you had unmuted yourself.
Sorry. I think too, just assuming that weight loss, like substantial weight loss, is realistic and possible and healthy, is a big one too, right? That like, oh, well, you should just lose weight without us actually having reasonable mechanisms for people to substantially change their weight status in ways that are actually healthy and sustainable.
Yep. Such a great point, Jessica. Thank you. I think that is something that we see a lot is just this, maybe prescription of weight loss is our only option for patients to achieve health outcomes or to achieve health goals. And that's not possible. Like we talked about with some of those myths, that's not possible for a lot of patients just through behavior change or just through diet change or exercise change. Depending on their history with disordered eating, that might actually not even be a biopsychosocially recommended thing for that patient, right? So what other options do we have for patients who want to achieve health when weight loss is not a goal or it's not an option? We have a lot of options for weight loss, and obviously we have these new class of medications that I think a lot of our patients are wanting to try. But I think that there are pros and cons to a lot of the options that we have for patients, and that we don't always talk through all of those pros and cons thoroughly with patients as they're trying to make this decision. I'm making sure. Oh, yes. So Ashley says, assuming issues are solely related to the patient's weight. Yes, 100%. So I see this all the time with chronic pain or joint pain, is that the only recommendation, this is kind of echoing what you said, Jessica, but the only recommendation that we're giving patients is weight loss. Well, what happens when that's not possible for various reasons? How are we going to treat the pain? And how are we going to treat this patient with equitable care as we would a thinner patient? What types of questions would we ask a thinner patient with joint pain? What types of treatment options would we offer them? Why aren't we offering those to patients of all sizes? So great point. So Lexi says assumption of someone overeating. If they are in a fat body and are denying or invalidating someone having a restrictive eating disorder, yes. When in a fat or not thin body, yes. This is so important. We have so many assumptions about food behavior and exercise behavior just by looking at BMI and weight. We also have assumptions about what an eating disorder, what disordered eating looks like, and what types of bodies that someone might have who has an eating disorder or disordered eating. Eating disorders don't discriminate. We know this. They are across all body sizes, and we see this. They're equal levels of and equal prevalence across all BMIs. But when we assume that someone doesn't have a disordered eating history, just because of their BMI, and then we're actually prescribing them disordered eating behaviors as a treatment option. That's really not great, right? Eating disorders are extremely dangerous, and we want to make sure that we're aware of that context. Yep, supporting disordered eating behaviors when they are starting to lose weight. So we see this a lot where the main goal is weight loss, but we're losing sight of all the context around it. So we're not asking questions that we would for a thinner patient who might lose weight. We're not asking those same questions on what's leading to this weight loss. Sure, maybe we're seeing some cutting back of certain foods, but would we label that as disordered eating in a thinner patient? And why aren't we labeling that as disordered eating for patients in larger bodies? Yep. The use of the BMI, despite it being an inaccurate measurement. Yes. So this is something that I'm about to talk about is BMI and some of the limitations of that. So I believe that might even be, is it the next slide? No, it's the next slide after this, but we're going to get to that. Thank y'all so much for all of these comments. So we're first going to focus just on some prevalence and some different things about weight stigma, specifically in primary care. So it occurs at extremely high rates. There's a study of 14,000 adults across 6 countries. This is specifically looking at their experiences within healthcare. 2/3 of the participants in each country reported experiences of weight stigma from their doctor. That's a lot of folks. So 2/3 of participants reported experiences of bias. And what we know is that implicit and explicit bias from providers leads to avoidance of care. Actually, up to 42% of folks avoid their primary care provider for fear of being stigmatized or being discriminated against. That means that a lot of people aren't getting life-saving care that they need because they're not going to the doctor because it's not a safe place. We see that there's distrust with their provider. Obviously, as behavioral health clinicians, we know that trust between physician and patient, between us and the patients, is so important. And when there's a lack of trust, that really inhibits health outcomes. It inhibits our ability to support the patient in achieving health. There's poor adherence to any recommendations, which makes sense, right? If you're feeling like you're just getting blamed or you're just getting shamed for your experience and it's not a safe space, why would you trust the doctor and trust any guidance that has been given? So there's poor adherence to any recommendations, which can lead to more stigma, and it's a whole cycle that can happen. And there's also poor communication in the patient-provider interaction. So when we have biased attitudes or stigmatizing attitudes towards our patients in larger bodies, our communication suffers. And once again, we know that communication between providers and patients is so important in creating a safe patient-physician alliance. So basically, weight stigma in primary care is happening at really high rates. And it's also leading to so many negative outcomes, not only for health, but also in that physician-patient relationship. And so this is a really important thing for us to be paying attention to, because we also know that providers who are specializing in obesity-related issues, so issues where we might see a higher prevalence of patients in larger bodies with certain issues, such as type 2 diabetes, this is where we see the highest bias. This is so frustrating, right? And upsetting that our patients who are most at risk for weight stigma are going to providers who maybe the bias is at the highest rate. So this is something that's really important. It's a social justice equity issue, right? That we need to be paying attention to. And those perceived, we do know too, just across stigma. So this is not even just weight stigma, but we know for health outcomes that across different types of stigma, so racial stigma, gender stigma, sexual orientation stigma, contribute to prolonged exposure to stress hormones, which can lead to heart attack, stroke, depression. These things are often outcomes that we associate with obesity or with weight, right? So again, it just begs the question, obesity or stigma, right? What role is obesity and weight playing? And what role is stigma playing? And how can we advocate for that conversation just to be happening more? There's a lot we don't know. Like I said, weight does contribute to health, but are we talking about it in effective ways? Is it contributing as much as we're saying it is? And is maybe stigma playing more of a role? And so why not shift our efforts to tackling stigma with the same maybe ferocity that we see and tackling different things like quote unquote obesity? So let's talk about BMI. So this was originally developed in 1842, but widely adopted in 1972. This is the measurement that we use to talk about weight, and it is basically the height-weight ratio. So it's simple, cost-effective, and accessible, and it's a way that all providers and all healthcare systems, all scientists use to measure weight. However, there are so many limitations to this measurement that is so widely used, and that actually lacks a lot of evidence, which is interesting that we use it so widely. There's super arbitrary cutoff points with lack of evidence on what is underweight, what's normal or healthy weight, what's overweight, and what's obesity. There's not a lot of evidence to support where those cutoff points actually are. Well, there was actually a shift in the cutoff point. I believe this was in the early 2000s, where the overweight, quote unquote, BMI was lowered. So overnight, all of a sudden, folks were labeled as overweight, where that's never been a label that they've been told before. When you look at the evidence behind why that was changed, it's kind of questionable. There's a lack of cultural and gender generalizability. So, I mean, the original BMI measure was based off of white cis men, and great for white cis men, but a lot of our patients are not white cis men. But we still use this measurement to talk about their height and weight ratio. We know this is different for folks who have gone through hormone treatment or gender affirming surgery. This is different for women. This is different for folks with different ethnic and racial identities. But we're using a very white, very male, very cis-centered way to measure height and weight. There's also a lot of faulty causal relationships to health outcomes. So there's been some studies where half of participants classified as quote unquote overweight, 29% classified as quote unquote obese according to BMI, were both cardio and metabolically healthy, right? So we're not seeing maybe some of that relationship. Whereas 30% of participants classified as quote unquote normal weight had poor cardiometabolic health. We also know that BMI is a barrier so often to life-saving surgeries due to these really arbitrary cutoff points. So folks who are needing gender-affirming surgery, folks who are needing life-saving care for their physical health, a lot of times they're told they have to lose weight in order to receive this surgery. And again, we know that that's not effective, right? We know that people are not able to lose a lot of times the amount of weight that they would need to for that surgery, or what they're being told. So what are our other options? How do we invest in figuring out other ways for folks to get the care that they need? And without weight loss being the only way to get that care. So yeah, BMI, I'll stop there. There's so many things we could talk about with BMI, but basically I think it's important to know that it was maybe not created with the most diverse sample size. It was also, there's some pretty arbitrary cutoff points, yet it is the most widely used way to talk about weight. So there you go. What we do know from research, and this is actually a pretty recent study, is you can see quite a big sample size here, and it's a longitudinal study design, so yay for that. That means we can imply some sort of causality, depending. But while we did see that there was an increase in mortality risk for folks with a BMI over 30, there was no significant risk in mortality for adults with overweight BMI. So we did not see in the study any increase in risk for folks with that overweight BMI label. And that suggests that BMI may not increase risk for health outcomes for folks with an overweight BMI independently of other risk factors, which means maybe we don't need to be prescribing weight loss as the way to achieve health if we're not actually seeing it create some of these health risks or mortality risks that we originally thought. On the flip side, if my thing would let me go to the next slide. Hold on. There we go. When we're talking about weight discrimination and the risk of mortality, 60% increase in mortality risk related to weight stigma. This was a study back in 2015 and it was pretty groundbreaking when it did come out. Something though that has not really been integrated in our training when we talk about weight, when we talk about health. We know that there's a 60% increase in mortality related to weight stigma, and this was not accounted for by other common psychological and physical risk factors. So we were controlling for things like BMI, controlling things for past history of different conditions. So based on what we know from research, maybe being at a higher BMI does not contribute as much to mortality as we're told, but weight stigma maybe is contributing a whole lot more than we're told. So this is something to be thinking about. And I'm just checking in the chat here to make sure I didn't miss anything. So Kathy asked about any movement we see towards not using BMI in health settings. I would say there's not a lot of movement in that direction. I think that is something that's really important to advocate for. And I think a lot of it starts with just talking more about the role of weight stigma, talking more about the faulty relationship between weight and health, and starting to challenge some of the paradigms that a lot of our healthcare providers hold. This takes time, right? So we might not be able to jump from what we know and what we hope to see of no BMI use immediately, but it's thinking about how can we take some of those small shifts so that our physicians and maybe those in power can start to shift their paradigms so we can start advocating for this. So I'd be curious if y'all have seen any future movement, but this is something I think that is really important that we need to advocate for that change. We're in the early stages of it. Saying,
Right.
raise your hand. Yes.
Sorry. So something I have noticed recently, I have a colleague, a doctor. She is still continuing to use the BMI, but she's moving away from using terms like obesity and those sorts of terms. So she's using BMI, trying to use it more as like a factual, okay, according to research, BMI says this is what this means, but this doesn't place you in a specific category. This is just a number. And since this is the number that it is, this is what it might mean, and trying to work in that way. So that's one direction I've kind of seen it going. But that's only with one doctor in my little small town. So I don't know.
But that does matter, right? I mean, one doctor at a time in a lot of ways with our patients. That I think is a really powerful language shift of here's what your BMI is. It is just a factual thing of many that we're looking at. Also, here's what it means for health. Here's what it doesn't. So maybe being more educated on the research between BMI and health and being honest with our patients about that research. Love that. And I think that, like I said, even though it's maybe quote unquote just one doctor, that is what it takes. That's the power of an integrated setting, right? Is that we are able to use our relationships with our physicians that we're building to help shift some of these paradigms, even if it's one system at a time. That matters for our patients in really powerful and significant ways. So thank you for sharing that. That gives me a lot of hope. We see some of that with our residents and our physicians too, some more than others. And a lot of it is assessing where are they in that paradigm shift. So how can we meet them where they're at? Yes, so we're seeing also some of the barriers that insurance companies, in particular, are put up for some of these surgery. Yes, it's a big barrier, and so a lot of times they require an obesity diagnosis for certain treatments. Ugh, that is so frustrating. But it's also the reality of the paradigm we're working in currently. So I think a lot of times it's being transparent with our patients about this, right? Here's what our insurance system, here's the limitations of the system that we're in. Here's why I'm going to put this diagnosis in your chart because it gives you treatment that you need. Here's what, and talking through, here's what this diagnosis of obesity actually means. It doesn't actually mean XYZ. Having just honest conversations about the meaning, kind of similar to what Amani was saying. I think advocating, thinking about ways that we can advocate for policy shifts in the insurance space of how different health conditions can happen across the weight spectrum and how do we advocate for more equitable access to healthcare. And I think that there's talks about how we can be more involved at a policy level. And I think insurance is an important one for sure. So some reflection questions, and y'all have done just such a beautiful job of reflecting. I'll leave this up for a little bit just for y'all to think on or write anything down that you would like, but I want to make sure we have plenty of time to talk about how this looks like and in practice with our physician colleagues. These are questions that come from the Red Center of Food Policy. They have some really great resources, particularly for families and parents and kids, of how to talk to these families, how parents can talk to their kids in less stigmatizing ways about body image, about body size, about weight. But these are some reflection questions that they had that I thought were helpful and something that I hope that I'm continually reflecting on when I'm about to see patients. So thinking about what are some assumptions that I make based only on weight. When I see a BMI in a chart, am I making any assumptions about their character, about their intelligence, professional success, health status, lifestyle behaviors? The reality is I'm still exposed to a system where there is a lot of stigma. And so I'm still hearing stigmatizing language a lot, which makes me not immune to some of these attitudes seeping in. So how can I constantly be challenging that? Could my assumptions be impacting my ability to help my patients? Is my assumption about their intelligence or their character or about their health status, is that changing the quality of care that I'm providing? Or is it changing the quality of care that I'm advocating for when working in an integrated space or collaborating with a provider? How comfortable am I working with patients of different sizes? Do I notice a rise in anxiety or nerves when I see patients with larger bodies on my schedule? Does that create an emotional response? And if so, why? How do I challenge that? How do I sit with that emotion and start to create a new emotional response? What are my views about the causes of weight gain? And we've talked about this. And how does that impact my attitudes about people with higher BMIs? Some reflection questions that no matter how long that we're doing this, it's important to continually check in with our own assumptions. So let's talk about tackling weight stigma in a healthcare primary care setting. So basically all that we've talked about, and if y'all have said, what we're doing isn't working. So we need to figure out a new way. Even if weight loss is our goal, we see that average weight and metabolic rates are rising each year. So whatever we're doing within our healthcare system, it's just not working. And so we got to talk about different ways to approach this. Another thing is recognizing and framing this as a social justice and equity issue, because it is, right? We're seeing a difference of quality of care provided to patients based off of a piece of their identity. And that is a social justice and equity issue. That means that there is an inequity in quality of care across our patient populations. And so regardless of where that inequity is, it is our role to advocate for equity, equality, inclusion across all different pieces of patient identity. We want to work to remove that burden of change, just like with any other discussion we have about bias, about stigma, about discrimination. We want to make sure that we're not putting the burden of change on the individual experiencing the stigma, and instead we need to put that back onto the system perpetuating it. So how can we start to think more systemically rather than individually? How do we start to talk about some of these bigger paradigms rather than maybe expecting individuals who are experiencing stigma to be the only ones to advocate for that change? Sometimes that is part of our role, is to help model or to help coach our patients of how to advocate for themselves in a visit with their provider. But how can we also think systemically so that we're not only putting that responsibility on individual patients? We also need to advocate for more research to explore that complex relationship between weight and health outcomes. We have so much funding going to obesity research, but as we're seeing, maybe some of that funding needs to be going towards weight stigma and the role of weight stigma, and also just the more complex relationship between weight and health outcomes. How can we figure out some different interventions, some different treatment recommendations that aren't just weight loss? So, some things to keep in mind as we're talking about this. So again, like I said, the first thing is thinking systemically and not individually about barriers to weight loss. So how do we start to shift blame and responsibility from the individual to systemic barriers? How do we maybe start to advocate for that with our physicians as well? If we're talking about a patient, how do we start to maybe use some of those curious statements or I wonder statements? I wonder what maybe systemic barriers might be getting in the way of their weight loss goal or of your weight loss goal for the patient. Have we talked about that with the patient? Have we explored that? Perhaps they live in a food desert. Perhaps they have experiences of poverty that are impacting. Perhaps there's a history of trauma. There might be genetic components, underlying health conditions, or experiences of weight bias or weight stigma. So how can we maybe start to think more systemically about the contributors to those barriers of weight loss rather than just individually? How do we start to facilitate health-focused rather than weight-focused conversations? So a lot of this is focusing on health behaviors and health indicators. So those outcomes that we're measuring in labs, health behaviors such as movement or eating a variety of types of foods. How do we talk about that instead of just weight? A lot of time we only focus on the weight, which actually means that we're using all sorts of unhealthy behaviors to achieve this said weight loss goal. So how do we focus instead on helping patients make goals on using these health behaviors or health indicators? Maybe their goal is to increase or to improve their blood pressure. And so maybe then we talk about what are some health behaviors that get us there. We're talking about the health indicator rather than the weight. We want to avoid immediately blaming patient symptoms on the weight. So exploring organic Root causes. Maybe for thinner patients, doctors might be more willing to explore these root causes than for our patients in larger bodies. So when collaborating with physicians, maybe advocating for this, of, I'm wondering, have we run labs for their thyroid? What does their thyroid levels look like? Are there any organic causes we haven't explored that could be contributing to weight or their weight gain, apart from individual behavior? So asking these open-ended questions in our conversations with physicians, and again, it's collaborative. It's not blaming of the physician, but it's maybe opening up some conversation about what might be contributing apart from to their patient symptoms, apart from just the weight. Again, focusing on health, not just weight. Making sure that we're giving patients of higher weights the same weight, time, and attention to individual symptoms that you would a thinner patient. So I think that a lot of times this is our physicians who are maybe providing this type of care for a patient. So how do we make sure that we're advocating for that we're spending the same amount of time on exams? I don't know who all is in resident education. Might just be Angela and me. But for those of us in resident education, when we're doing observations, when we're a part of that training, how do we coach them, or how do we start to model early on in the training to spend equal amount of time with all patients? Asking the question, if this patient had had a lower BMI, would there have been other things that you might have asked? What might be some ways to incorporate those into this visit with this patient? Maybe let's go back in. Let's ask some of these questions. So how do we maybe work with residents if we're in that space? When a patient comes in with diet change goals, exploring the reasons behind those goals, right? So a lot of times our patients are coming in with goals of weight loss. They're coming in wanting Ozempic, wanting Wegovy, wanting Mounjaro. They're coming in wanting to make diet change goals. This isn't necessarily bad, right? Part of this is making sure that we are not placing judgment on any of our patients' goals, that we are being patient-centered and making sure that our goals are aligning with what the patient says that they are. But our role as providers, and part of shared decision-making, which we'll talk in a second, is making sure that we're providing our knowledge for that. So how do we counsel patients on how diet change can improve health outcomes sometimes, but it's not necessarily going to result in weight loss? How do we make sure that those expectations are there? How do we help them shift? Okay, if we're wanting to improve certain health outcomes, maybe we can make some diet changes in certain ways. Maybe we can add more types of foods into our diet. Maybe we can, think about, okay, I need more energy, thinking about more internal cues. How do we have some of those conversations? But again, maybe helping our patients see that diet changes does not necessarily equal weight loss, and helping them to make that shift too. So yeah, if we remove weight as a goal of dieting, what other reasons could there be to change diet? And sometimes patients might be like, oh, wait, I don't have another reason. So there is a perfect opportunity then to explore, okay, well, what's a relationship to weight? What's a relationship to body image? What's a relationship to food, right? A lot of times maybe the goal of dieting or the goal of making a diet shift is primarily for weight loss. So when we remove that from the conversation, it can also help highlight that for our patients of, wait, what is my goal for this? Maybe this isn't as health-centered. Maybe this is weight-centered, and maybe there's some work as behavioral health providers that we can do with our patients with their relationship to that. So practicing shared decision-making and conversations about weight loss. So first and foremost, establish if weight loss is even a goal, right? That sentence that I typed did not make a lot of sense, but what I just said, hopefully it made more sense than what was on the screen. So first, talking with a patient about, is weight loss even a goal? And this might not be something that we as behavioral health providers, or we maybe who are farther in our paradigm shift on weight, necessarily, we might not be having that as much as a part of our conversations and behavioral health visit. But if we're working with physicians all the time, they're going to go in and the assumption is weight loss is the goal for everybody. So how do we coach them? How do we gently, curiously ask questions on, what did the patient say that their goal was for their health? Do we know what the patient goals for health are? Again, if we're working with residents, coaching them to ask, well, first, before we talk about weight loss, let's ask if that's even a part of their vision for their health or part of their goal for health. So taking it all the way back and first getting even consent that this is a goal that our patients have. Critically thinking about the pros and cons of weight loss and talking about that with our patients, right? And making sure that we are taking a multifaceted, individualized patient approach versus a flat recommendation just based on BMI. Every patient is different across BMI. Every patient has different health goals. Every patient has different health conditions. Every patient has a unique trauma history, has a unique context in which they're living, and they have different health needs. So how do we make sure that we are not just going in with assumptions and recommending things just based on BMI? How do we maybe coach and model that for our physicians of, what are some ways that we can ask more individualized questions rather than just providing flat recommendations based on BMI. So an example is if a patient is experiencing chronic pain and a physician says, okay, weight loss, that's what we're going to do to manage this pain. Maybe gently and with curiosity, with using our great skills with I wonder questions, all the good stuff. I wonder what this patient's history is with disordered eating or with their body image. Have we talked about that with them? I'm wondering if that might be an important thing to consider when making recommendations about weight loss. Or I wonder if that might be something that would influence if weight loss is even an appropriate recommendation for this patient. Maybe let's go in and get some more information about that first. So again, how can we maybe help our physicians expand their context and ask more questions about some of that psychosocial piece of a patient history before making recommendations for weight loss? Also thinking about communicating the limitations of weight loss with patients, right? So patients are coming in and they're identifying weight loss as a goal, or they're identifying that they want to go on Wegovy, on Ozempic, giving them all the information. Again, if that's their goal, and I know there's a lot of barriers right now with insurance with those medications, but if that's their goal, that's not necessarily our job to change their mind, right? We're not there to tell a patient that this shouldn't be their goal, but we are there to give them all of the information they need to make a well-informed decision, right? So making sure they know that research is not super well defined on the sustainability of weight loss. And that's really important in giving them autonomy over their decision, right? So maybe they've been told from diet culture, just from the world we live in, that weight loss, this diet change leads to weight loss. This medication leads to weight loss. This surgery leads to weight loss. How do we make sure they know all of the components of that? Let's talk about how weight losses can be difficult to sustain. So do we have other health goals? Again, shifting it back to health. What are our other health goals apart from weight loss that we're wanting to achieve? Is this the best way to achieve that health goal? Or can we talk about maybe health behaviors that might be a better fit? If they're wanting bariatric surgery, or if a physician is wanting to recommend that, let's talk about the pros, but also let's talk about the cons of what we know about outcomes. We know that bariatric surgery leads to extremely high levels of suicidality. We know that it leads to very disordered eating behaviors by necessity. Let's talk about that, individualized with this patient, knowing their history with disordered eating, knowing their history with suicidality. Let's talk about that. How do we make sure that we're being transparent with our patients so that, again, that's shared decision making? Patients are able to have all the information that we know from research to make autonomous decisions about their goals related to weight and health. We might provide them with all this information and they say, no, I'd still want weight loss to be a goal, or I still want to go down this path, and that's okay. That's the thing I struggle most with sometimes, is allowing my patients to set their own goals on the opposite side. And sometimes I have to be like, okay, this is a patient-centered goal. This is what they're wanting. I've given them all the information. And now my role as a provider is to support them in their goal and continue to give them information as I have it. Continue to help them to deepen their thought process about their goal. But ultimately, it is respecting their goal. But I think so often we're quick to just prescribe the Ozempic. We're quick to just say, okay, yes, let's follow this diet plan. Let's do this without actually giving patients all the information they need about the dangers of weight cycling, sustainability of weight loss, maybe questioning what other reasons we have besides weight loss to reach this goal. So these might be some ways that we can help expand the paradigm for our patients, but also with working with physicians. So even asking our physicians when they're talking about this with patients, have we given them all the information about sustainability of weight loss, or about maybe some of the limitations of diet changes with weight loss? This might be important information for our patients to have in making a decision for their health. So some things to be thinking on for sure. Another thing that we want to be aware of is that restrictive food rules lead to disordered eating across body sizes. So when we're practicing shared decision making and we're having those conversations with patients, or we're hearing whoa, I don't know what just happened there. Y'all ever seen that happen? I have not. Don't know what I said, but Zoom said retweet. So we need to be aware that when we're prescribing different food recommendations for patients, that if we were to take this recommendation that we're giving this patient and put it on someone who is quote unquote underweight or normal body size, quotes, if that would be considered disordered eating or a risk of an eating disorder, then why are we prescribing that, or why are we recommending that for patients in larger body sizes? Something that also we can challenge gently, but challenge physicians on this. This can be a good paradigm shift of why. I'm curious of of how you think this person might practice some of these eating behaviors, and why that might be less dangerous than someone who might be this size. Or I wonder, this person also has some history of disordered eating. I wonder how that impacts what you're recommending. So again, we're just asking our physician colleagues to consider some of these psychosocial pieces, consider maybe challenge some of those beliefs about weight. And again, one step at a time, right? We're really leaning on that relationship and using that as we're talking with physician colleagues. But also we're leaning on that relationship with our patient. We're practicing that patient-centered care. We're making sure that their goals are the center of the conversation, and not ours as providers. And we're helping physicians do the same thing. So I know we have a little bit. We have 3 minutes left. But some final thoughts is facilitating direct conversation about weight stigma experiences with our patients. A lot of times we avoid this conversation. A lot of times we avoid talking about stigma or discrimination in general. So maybe coaching our providers and also us ourselves to just ask and facilitate a conversation. Saying something, weight stigma is something many of our patients have reported experiencing often, especially in healthcare settings. That's something that I'm aware of, and I want to make sure that we do our best to create a safe environment for you here. I'm wondering if you have experienced this in the past, and if so, if you feel comfortable sharing more about those experiences. So how do we open up this conversation so our patients know, oh, we as providers, we're aware of this. We are constantly open to this conversation about making this space and this healthcare space, this primary care space, safer for them and more inclusive. We're open to that conversation. And then finally, checking your own weight bias. And I think, all sorts of bias. Maybe white supremacy there, but checking your weight bias and seeking education. So how do we make sure that, again, we're spending equal time addressing root health causes with BMI, with patients across the BMI spectrum? Being aware of immediately suggesting weight loss as a solution. So these are examples of biases that we want to challenge, and we've talked about that. Advocating for weight stigma education in medical training, but also in our training as behavioral health providers, whether that be marriage and family therapy training, LPC training, whatever that looks like. How can we advocate social work training for weight stigma to be a bigger part of that? Paying attention, like I said, to our emotional reactions when seeing patients with higher BMIs on the schedule and being honest about that. We all have bias, right? We live in a society that is inherently stigmatizing people in larger bodies, and just like all sorts of different types of stigma, we're exposed to this and we're internalizing it. And so we need to be honest with ourselves about where those biases are and paying attention to our emotional responses so that we can do something about it and we can seek more education. I'm going to wrap up with this slide, 1 minute to spare, with some future resources or further resources if you're wanting to continue this journey or this learning journey or this conversation outside of this lecture. This is such a complex, nuanced topic, and I could talk about it for a long time, but today we had an hour. So if you want to spend a little bit more time, these are some things I recommend as places to start. Maintenance Phase is a fantastic podcast. Aubrey Gordon, who is the author of these 2 books that I also put up here, is one of the hosts, and she identifies as fat and has a lot of lived experience with weight stigma. These 2 episodes in particular, the obesity epidemic and anti-fat bias, I think are especially helpful places to start. And then, like I said, her 2 books are fantastic about her experience and also rooted in a lot of evidence and research as well. She's a journalist and has really done her research well with this. And so her lived experience mixed with this evidence, I think these are important books that we can also recommend to our physician colleagues if they're wanting some future resources. And finally, for my fellow nerds who just like to read research articles, here's some fantastic researchers that are doing some really cool work on this topic, on the role of weight stigma in health. So you can just set that Google Scholar alert, and then it'll email you whenever they release any new articles or write any new articles. So that's what I do. And finally, this is the Yukon Red Center for Food Policy and Health. I mentioned this, but they have a lot of really good resources for families and how we're maybe modeling and coaching families to talk about weight or body image or food with their kiddos. So a great family resource here and one that I think could be really helpful for those of us in primary care or family medicine, especially for my fellow family therapists out there. So thank y'all so much. I know we're 1 minute over, but I really appreciate y'all's time today. And what a great conversation. Thank you so much for everything in the chat and everything y'all contributed. I have some good stuff to be reflecting on too, based on the thoughts that y'all brought up. Feel free to email me at any point. I love talking about this topic. So I'm happy to continue that conversation via email, and I will make sure Angela has these slides so that y'all can have that as well.
Awesome. Thanks so much, Maggie. This was super interesting and a super important topic. So it is being recorded, and I believe it will be on the CFHA website, but also we'll be sure to get the PDF version of this from you, Maggie, and send it out.
Awesome.
All right. Thanks, everyone. Have a great rest of your Thursday.
I'll shoot my email into the chat really fast.
Thank you.
That would be important. It's pretty easy. Margaret.smith@utsouthwestern.edu. Boring academic email, but there you go. Yeah, there is another Maggie Smith. That's not me. So Margaret Smith for that.
Maggie,
Oh, wait.
thank you.
It's
Send
gonna
it
go to
just to me.
everybody. Let me send this one more time. It's challenging my typing speed here. Okay, there we go. Now y'all can have access to that. Like I said, feel free to email me at any point.
All right. Bye, guys.
Bye.
Thank you.
Your week.